I'm Dr. Ramyar Mahdavi. I'm interventional pulmonologist. In July 2024, I came to Adventist Health to start the interventional pulmonology program. If I want to categorize the work that an interventional pulmonologist can do for the patient, and not only for the patients, for referring physicians in different specialties like internal medicine, like oncology, medical oncology, radiation oncology, thoracic surgery, and pulmonologists, that they refer their patient to us for two different reasons: diagnostic procedures and therapeutic procedures. For diagnostic procedures, I would categorize in two or three different kind of diagnostic procedures. Diagnostic of airway diseases with rigid bronchoscopy, doing biopsy from the airway, doing biopsy from the pleural space with the medical thoracoscopy, which can be done under even conscious sedation, not general anesthesia. And for the therapeutic purposes, we can categorize in three different categories: airway diseases, lung parenchymal diseases, or pleural space diseases. I remember a case that I performed as a diagnostic procedure with robotic bronchoscopy for the diagnosis of lung cancer. That patient was a 68-year-old female with no smoking history, had a very small nodule in the right upper lobe. It was, if I remember, 4 millimeter or 5 millimeter, and it was ground glass opacity nodule. It has been grown for, I would say, 1 or 2 millimeter over 2 years period of time. The pulmonologist that taking care of the patient sent the patient for CT-guided biopsy, and it was negative for cancer. So the patient was happy that, okay, I don't have cancer. Another CAT scan in 6 months performed, and the ground glass opacity increased just 1 millimeter in size. The patient referred to me. We did robotic bronchoscopy, and we get a good biopsy, very, very precise biopsy, enough for detecting all of the genomics for pathologic evaluation, because we use cryobiopsy when we do robotic bronchoscopy, meaning a good chunk of tissue for pathologists to diagnose the lung cancer or any other problems with the lung. That came of adenocarcinoma of the lung. We did the EBUS or endobronchial ultrasound for staging of lung cancer at the same time in same session of anesthesia, and it came N0, meaning that no lymph node was involved with the cancer. So the time frame from basically when I saw the patient for the first time in my office, when the patient referred to me, and getting the diagnosis, basically meaning that performing the robotic bronchoscopy and having the pathology results was around 10 days. We referred the patient after this diagnosis to the thoracic surgeon within our health system and got a surgery, removal of that part of the lung, and the patient was cured. If we didn't diagnose this lung cancer, despite the fact that she had a biopsy before with the CT guided, and she was happy that, okay, I don't have lung cancer because the biopsy was negative. But with our biopsy, which was very precise, we diagnosed lung cancer in very early stage, and the patient was cured.